because I want to try to give you guys enough time to do a quiz as well. So some of these we're going to try to go through kind of quickly, especially if I feel it's kind of non-pertinent information. So we're finishing up Pathophys with this chapter 12. And a lot of this information, we have roughly 70 slides left of this to go through tonight. And then you'll have a chapter 12 quiz, which will be due by, let's say, next Tuesday, next class time. Nothing that we haven't gone over is on this quiz. I picked out all the questions for the quiz. It's not, I actually went through, it's only 25 questions. It's not like it's going to be super hard. Obviously, you can still use your book for this. And then at the end of tonight, we'll kind of talk about the final. I'll give you enough time if you want to do your quiz tonight. You're more than welcome to. Again, it's only 25 questions on D2L. And as soon as we end, I'll go ahead and unlock that quiz so you guys can access it. Are there any questions about anything before we kind of get going? All right, then let me get my screen turned around and we'll get moving. All right, where we kind of left off last week was talking about different blood types, right? So we talked about, your O, your AB, your B, your A, and how they were kind of really interacting with each other. So obviously A is going to be our universal donor, as to where AB is the universal recipient because it carries both A and B type antigens. Remember antibodies, right? They're things that fight antigens. And an antigen is anything that enters our body that shouldn't be there, that's foreign to us. So these antibodies serve 4 different types of functions, okay? They neutralize bacterial toxins. They neutralize viruses. They do something what's called opsonization of bacteria, which I'll cover here in a second, and then activation of the inflammatory response. So let's talk about some of these major functions and what it truly means. When we talk about neutralization of, bacterial functions, what we're truly trying to essentially mean is that bacterial toxins, when they come in, they trigger an immune response of our body, right? These antibodies rush to the site when an antigen comes in and try to neutralizing them by essentially finding out the sites that they're trying to occupy and going in there and occupying the sites themselves. Kind of like Narcan does with opioids, right? So they're essentially not killing the bacteria or the toxin, but they're occupying the site so that the toxin can't do the job that it's supposed to be doing. And it's very similar with viruses, right? So viruses, when we talk about antibody attaching and killing a virus, we're talking about something called phagocytosis. And phagocytosis is really the destruction of a virus by an antibody. And then we have opsonization, which is an outer shell. There's an outer shell that all bacteria generally have, right? And it's resistant. It's almost like a defense for them. It's a little wall that antibodies have to try to get through. So what happens is this bacteria is coated with this substance. It doesn't essentially make them indestructible, but it makes it a little bit harder for antibodies to attach themselves because it almost makes the antigen slippery itself. So the antibody recognizes this and tries to coat the bacteria with something to kind of degenerate that wall first before going in and attacking it. And then the activation of the inflammatory process. When we talk about inflammatory process, what are we thinking right off the bat when we talk about inflammation?
Swelling.
Okay, so swelling, right? We get red blood cells to rush to the area. We white blood cells rush into the area. And essentially, they're trying to attack some sort of foreign invader or foreign bacteria or a cut or anything like that. That's why if we generally get like even just a small cut on our arm or a small cut on our finger, it usually swells up pretty quickly, right? Because we get that rush of different types of blood cells to the area to try to fight whatever's going on because they're unsure, right? They're just kind of, they're not targeting something specific. They're just trying to fight anything that they can at that point. Now, when we talk about immunoglobulins, all immunoglobulins are antibodies, certain types of antibodies. So, again, I don't expect you to memorize this, but I would know where to find it in your text because it's kind of important, and it might come up in your quiz. So our first one is IgM, which is our largest antibody, is what we'll call it. It is really what's produced during the primary immune response. When initially the body recognizes there's an antigen coming into the system, it doesn't know what to do. It activates the IgM, right? It's kind of like a catch-all, a coverall when we talk about antibodies. We have our IgG, which are our memory cells. Remember how I said last week that certain antibodies will look for certain antigens. And when they first see them, they don't know how to react to them. But as that antigen keeps coming around more, that IgG antibody is what recognizes that this is potentially harmful and goes in to attack it. We have our IgAs, which are mostly mucous membranes. So we're talking about nose, we're talking about mouth, we're talking about how do we, try to get bacteria or viruses out of that? Well, through mucus out of those orifices, right? We sneeze, we cough. IgEs, which is the principal antibodies having to do with allergic reactions or anaphylaxis. And then IgDs, these are really developing B cells. And what a B cell is a certain antibody that is designed just as an attacker cell. That's all its only job is. B's and T cells, some of them are just attacker cells. All right, so immune system. We talk about mucosal membranes or endothelium, protect bodies from pathogens inhaled or ingested. So how does our body respond to that? Say we have an antigen entering our nose. How does our body respond to that? I know we've talked a little bit about it.
Passively tries to locate anything coming in, okay, and then activate a more active defense system once it identifies.
Okay, so if something's coming in our nose, how does it automatically, what's the first thing it does? It sneezes. Same thing can happen if we ingest something, as our body's natural reaction could be to try and puke it up as well. Has anybody ever heard, like when COVID was really, running rampant, and they were talking about like I'm trying to think what they called it. An enhanced immune response during COVID, that their body was essentially attacking itself, right? I think I talked about that a little bit as well. That's what we call cytokines. And a cytokine is a protein produced by white blood cells, and they're messengers of the immune response. So really, they are the ones that are detecting that something is wrong, activating this immune response, going back to the white blood cells and saying, hey, yeah, we have an intruder of this known origin. That way, the white blood cell knows if it can attack it or not, because without that, it really doesn't know if it's something that it can go for. It doesn't know if it's something they can essentially try and kill. So these cytokines, they bind with nearby cells, or they can bind with the same cell that produced them, and they help regulate functions such as your inflammatory and immune responses, right? Monokines are cytokines released by our macrophage. Again, I don't expect you to remember what a macrophage is. And then a lymphokine. What I do want you to remember is we focus on T and B cells. Remember, T cell is more of a helper cell, as to where B cell is more of an attacker cell. So a T cell might help the immune response attack something, as to where the B cell attacks it primarily. This is the boring part of pathophys, so just bear with me. As we get older, right, immune function begins to deteriorate. Pretty normal. You could say on the other end of the spectrum as well, the younger we are, it's the same thing. We don't have that immune response yet. We don't have that buildup, right? Primary assault is on T cell function when you get older. So you lose the ability for your T cells to essentially help attack foreign antigens. We kind of talked about inflammation already. So as soon as some sort of injury or immune response develops, our body is going to automatically inhibit or kick in our inflammatory response system, right? And it can either be specific or non-specific. And specific means that a certain antigen that we might be allergic to, such as peanuts, such as pollen, shellfish, those are specific immune responses, as opposed to one where maybe you just have a common cold and maybe, I don't know, your lungs become inflamed, your mucosal membranes become inflamed. That's just a generalized. That's not because it's looking for something specific. It just knows there is a foreign invader and it's trying to attack it. It's just not sure what it is yet. Again, specific is it targets something specific, such as an allergen or an allergy that we know of. That's where non-specific is it attacking something that it isn't sure of what it is at that point. Immune response, long-lasting. Inflammation is temporary, right? We can reduce inflammation, especially as paramedics. How can we try to reduce inflammation? Think of somebody that maybe they're sick and their lungs are inflamed. How can we try to reduce that inflammation? Or what is a drug that we can give that can reduce inflammation, even if we don't see it immediately?
Benadryl.
Okay, you could give Benadryl. So which is an antihistamine, right? So we're gonna stop a histamine response. We're gonna kind of inhibit the immune response. Not so much inflammation though. Think of your lungs. If somebody's lungs are inflamed, what's a respiratory drug that we could give to reduce inflammation? It begins with an S.
Solomedrol.
Solumedrol, absolutely. Solumedrol is a corticosteroid. We give because we might not see a response for solumedrol with our patients, but we give it because over time it'll actually reduce inflammation within their lungs. That's why we give solumedrol. It's not because of treating our patient that's right in front of us. It's doing what's best for our patient, even in the long run. So immune response, one type of white blood cell, such as a lymphocyte or leukocyte, is attacking something, as to where inflammation, platelets and white blood cells are gathering, right? That's what's causing the inflammation. Immune response, same thing. Immune response and inflammation kind of work hand in hand, but they're totally different systems, right? So our immune response is responding to an antigen, something that comes into our body that is unknown, as to where inflammation is more of a generalized thing, right? We can become inflamed for any reason. Sickness, injuries, cuts, infection can induce an inflammation response, as to where they will not always induce an immune response. If I cut my finger, my immune system probably isn't going crazy. It probably doesn't even care. My inflammation system is going, okay, we need to send some white blood cells to that area to try and fight potential infection. There's 4 different types of phases when we talk about inflammation and immune response. So let's talk about inflammation. Phase 1, acute inflammation, right? That is, again, I cut my finger, I've got a paper cut, very small, very generalized area, very localized area of inflammation specific to a certain point. Then we have chronic inflammation, where healing hasn't taken place, right? And now we've got an inflammation response over a longer period of time. We have granuloma formation. Does anybody know what a granuloma is by chance? It's essentially a long-term bruise. And then we have phase 4, which is the healing process. Now, the healing process can take a little bit longer depending on what type of inflammation. So if this is a chronic inflammation that's maybe patients been dealing with for a longer period of time, it might take a little bit longer to heal. These are patients that might be getting several doses of steroids to reduce some inflammation. Or maybe they do have a weakened immune system. Their body just can't fight off things like they normally would. So yeah, they do become a little bit inflamed, right? So we get 4 functions of inflammation now, right? Destroy and remove unwanted substances. We send all these blood cells to a certain area of injury because, not just for fun, right? Because they've got to attack what's going on. To wall off the infected, inflamed area. That's what inflammation does. That's why it gets really puffy around a certain areas, because it's trying to stop the spread, whatever it is in one area, and prevent it from moving to another area. It can, if severe enough, stimulate an immune response from our body, saying, hey, you know what? I've done my best here to try and isolate this. I'm not doing the best. I'm overwhelmed. I need the immune response to kick in, right? We need to start attacking certain antigens at this point. And then it's going to promote healing, right? By sending all those rushes of white blood cells to that area. Remember, white blood cells are essentially healers. So an acute inflammation is triggered by any injury, whether lethal or non-lethal to the body's cells. And when I say cells, I'm talking tissues, I'm talking organs, systems, whatever it could be, right? Cell injury can result from such things such as hypoxia, okay, so lack of oxygen, chemicals, maybe an inhalation injury, infectious agents such as bacteria or viruses or even parasites, trauma, sure, heat. What on the other end of that? Cold as well. Nutritional imbalances, genetic factors. Those are all things that can cause inflammation. Okay. Our blood vessels, they contract and dilate. What happens if our blood vessels dilate? What happens to our skin color if our blood vessels dilate?
Become pale.
Is it pale or
Red.
Turn red.
we turn red? What, right? Because we are now bringing the surface of that blood all to the surface of our body through vasodilation. Think of when we become really hot, really warm. That's because we're not turning red because the sun's beating down on us. It's generally because heat causes vasodilation, which makes you appear flushed. As to where if you found somebody that was hypothermic, out in the cold all day long, maybe it's 30 degrees outside, then we're wearing a coat, they are generally blue or pale in color, right? That's because their body's natural reaction is to constrict, is to lock down these blood vessels, because they want to conserve as much heat as they can to the core. And they do that by locking down the blood vessels in all of our extremities and at the surface of our skin. All right, so let's talk about mast cells. Mast cells, again, resemble bags of, let's just talk about like a bag of rice, right? They're the chief activators of the inflammatory system, right? So that these mast cells are what are sent to the area which identify what's going on, and they start the inflammatory process. They're not blood cells, but yet they reside just outside blood vessels. So they kind of travel along. Think of highway helpers, essentially what they are. So when they degranulate, think of this bag of rice. It empties its contents into the environment outside of blood vessels, and it looks for certain things such as physical injury to the body, chemical responses, immunologic responses such as an allergy, or any direct processes that the body is trying to fight off at that point. So mast cells are more just essentially something to help identify that we have an issue, right? And then they degranulate, they identify the issue, and they kick in the inflammatory response system. Little diagram here as to how our inflammatory process works. So initially, bacteria enters the tissue. It begins to damage our tissues itself. At that point is when our body recognizes there's a problem, right? It releases what's called mediators. These mediators increase blood flow to the area. They increase blood flow because now we can get more red blood cells, we can get more white blood cells to the area a lot faster. Bacteria are generally contained due to inflammation. Remember, inflammation isolates bacteria or isolates an infection to one area, and then hopes that our body fights it off. If not, our body then will induce our immunologic response. From there, once everything's attacked, our inflammation starts lowering a little bit, and the tissues begin repairing themselves. So we talked about, somebody brought up Benadryl earlier. And Benadryl, again, is an antihistamine. But if we're going to talk about antihistamines, then what is a histamine? What does histamine cause then?
Vasoconstriction.
It does. It causes vasoconstriction, absolutely, because it's a vasoactive agent. It causes vasoconstriction, but dilates the capillaries, right? It dilates the capillaries at the end of our blood vessels because it wants increased blood flow at the site of an injury. We talk about chemotactic factors, chemicals that attract white cells to the site of inflammation, and then chemotaxis, attraction of white cells themselves. Kind of makes sense when we talk about like chemotherapy. That's what's happening during chemo is we're attracting white blood cells to attack whatever's in that region. I'm going to skip over that part. All right, coagulation, so clotting. At the site of an injury or the site of inflammation, we get coagulation. Clots, blood clots, right? And I know I brought this up before. Fibrin is the chief clotting agent. In patients that have a reduced amount of fibrin, they potentially have a coagulation problem, right? What's one of the diseases we talked about last time when people have a reduced amount of fibrin in their blood?
Hemophiliac.
Hemophiliac, right? Because they don't have that ability to clot like they would normally. It's not that their blood's thin, it's just they lack that fibrin. So that's a good example of this is you get a cut or a little kid. Think of a little kid that scrapes their knee. They're out skateboarding, they're riding their bike, whatever it is. They fall down, they scrape their knee up. And what does that injury do over the next couple days? What does it do to where kids want to pick at it?
Scab.
It scabs up. Absolutely. That is nothing more than fibrin that has taken that has created that clot. That clot is made up of something called fibrin. So inflammatory responses of the body are the process of inflammation is actually powerful, potentially very damaging to the body if it is directed in the wrong fashion. That is why when we get patients that have like leukemia, an increased number of white blood cells, and they get an inflammatory response, but yet there's nothing for the body to fight, the body essentially attacks itself because it's, again, not specific to something like the immune system. It just thinks that it needs to kick it into high gear, right? All right, so lymphocytes, we have our T's and C and B cells. Remember, our T's are our helper cells. That's where our B's are attacker cells. Make up 25 to 30% of all white blood cells, okay? We have granulocytes, such as neutrophils, basophils, and eosinophils. And then we have monocytes. I do not expect you to remember this, and I would not test you guys on something like this because that would not be fair. I'm trying to get to the nitty-gritty stuff that I feel like you guys need to retain as paramedics. Platelets act with components of coagulation to promote blood clotting, right? Platelets, in addition to fibrin, promote clotting. Now, if we have a reduced number of platelets, like let's say we have a trauma patient, right? And we give it a massive amount of saline because their blood pressure is low. We now have reduced the platelet count, not by essentially forcing the platelets out, but by thinning the blood. But by thinning the blood, we've also reduced the amount of fibrin. That's why, when we talk about trauma, we're going to talk about something called permissive hypotension again, because we don't want to create too much of a cascade of saline to where we're washing blood clots away. We're actually doing more harm than good at that point. Those patients, that's why they give them packed red blood cells, RBCs, is because that contains fibrin, that contains platelets to help with the clotting factor. All right, systemic responses of acute inflammation. Remember, this is the short term. When we talk about acute, we're not talking about chronic at that point. So initially, we get a fever, increase in circulated plasma proteins. It's looking to fight something at that point, right? Why do we spike a fever? Does anybody know? Or what causes, or what, there's a certain chemical that actually causes fevers within our bodies. Anybody know what that chemical is called by chance? It's called pyrogen. Pyrogen is actually released when the body is exposed to some sort of bacteria, to some sort of antigen. So our body is trying to essentially burn whatever this is off, right? That's why it elevates in temperature. That's how us as paramedics can tell if somebody's really sick. Is yeah, they have an increase in temperature. That means their body's trying to fight something off. The thing is, though, a fever can have both beneficial and harmful effects, right? What do we know about pediatric patients if their temperature rises and stays at a high temp for too long? What happens to them?
Febrile seizures.
Yeah, we can develop febrile seizures. You can also get febrile seizures as an adult for prolonged fever as well. Again, a temperature can create an environment that is inhospitable to some microorganisms, but at the same time, it may increase an infected person being more susceptible to some types of bacteria. So it's a damned if you do, damned if you don't situation, right? Okay, our chronic response. Any response that lasts longer than 2 weeks. It could be caused by a foreign object, a substance that persists in a wound. Good example that would be like a splinter or possibly a piece of glass, or even a piece of dirt if it's gets into a wound. One of the things when I was a kid, anytime I got a splinter, what was the first thing you tried to do when you got a splinter as a kid? You try to pick it out, right? Even an adult now, if I get a splinter, I'm freaking out. I'm going for like the butter knife. I'm looking for something sharp so I can sit there and pick at it for the next 2 hours while I watch TV. Did you know, though, that your body's natural response, has anybody had a splinter, like a really bad splinter before that you didn't mess with? What happens after a little bit of time? What does that splinter start to do?
It'll become infected and your body will end up rejecting it, pushing it out on its own.
Exactly. Your body, it actually starts bringing it up to the surface, right? And until you get to the point that your body either totally degranulates it or breaks it down, or to the point it pushes it out. That's absolutely right. And it's the same with any foreign substance or any foreign object as well. So during this long period of chronic inflammation, the problem is our body cells start to degranulate, break down, and die because they're not used to fighting for this long. They're doing what they can. They're producing more cells of themselves, but as that happens, we have to start to begin to tear some cells down, right? Because if we have an increase in white blood cells and we just keep building them, that's where we start to form diseases such as leukemia. Okay. At the end of this inflammation, say that we've had an open wound, we've gone through this whole thing, we've gone through the infection, we're treating with antibiotics right now. We can develop scar formation or scar tissue at the final stages of inflammation. That doesn't mean scar tissue that we normally see, but scar tissue under the surface as well. That's why if you've ever had, like a severe cut or anything like that, and even if they stitch it up, they sew it up or whatever it is, we still get scar tissue. What is scar tissue? The issue is scar tissue itself doesn't have nerve endings in it, right? Everything in that is killed at that point. I broke my arm when I was, I'd say 9 or 10 years old, and I'd have surgery on my arm. If you ever look at my left arm, I have 3 scar incision points, one by my wrist, one in my forearm, and one in my elbow, from where they went in and put these metal rods in my arm. Where this scar tissue is built up, I can actually grab it if I wanted to with a pair of pliers and squeeze it as hard as I could, and I would not feel a thing. It's just because I had tissue death at that point, right? The tissue began to break down. The body rushed to the site and said, hey, we've got to fight this infection. But the downside of this is it might not look how it normally did. All right, local inflammatory responses. So vascular changes. We dilate or we constrict based off of what's going on. Do we need to open the blood vessels up? Do we need to constrict the blood vessels down? Are we in shock by any chance? Because if we're in shock, that usually means our blood vessels are dilated. So we got to try to either fill the container or bring the container closer together. Exudation, if you hear that term in the future or anything like that, it's to dilute toxins, essentially, and bring white blood cells to the site of injury. If you notice, there are so many different mediators or so many different types of cells that their job is literally just to identify that something is wrong and bring attacker cells to the site. It's just how our body works. We have a fail-safe for everything. When this injury is finally coming to a close, we have what's called resolution and repair, right? So when we talk about resolution, we're looking at complete restoration of a normal structure and function. We're trying to bring everything back to homeostasis, bringing it back to where it started at, right? We get regeneration. Think our skin has regeneration, right? Our skin essentially grows back. We shed a layer of dead skin, kind of like a snake. I know it sounds nasty, and then newer skin takes its place. We might have to, if you've ever heard of debridement, I'm not talking about medical terms as well, but our body does debridement as well. And it is essentially cleaning up the site of dead cells where this battle was fought of this infection, right? When we talk about like primary intention, minor wounds such as like paper cuts, they close and heal easily, right? They are said to heal by a primary intention. More extensive wounds, such as a wound that might need to be filled or a wound that might need to be contracted back together, are said to heal by secondary intention. So remember, primary intention is minor, secondary is more extensive. And when we get to that reconstruction phase, again, that's when scar tissue can essentially start to develop. That's when we get the initial wound response, the granulations, those cells start to break down, epithelialization, I try to say them fast, and then contraction. When we talk about initial wound response, we're talking about the sealing off the wound by a clot, contains a mesh of fibrin and generally platelets. Then we look at granulation. So repair begins with granulation. Tissues grow inward from healthy connective tissues surrounding the wound. While granulation is taking place and we're starting to grow new tissue, the scab is being dissolved at that point, right? The scab is starting to fall off because new tissue is starting to take its place. Then we get what's called contraction. And contraction is as the wound edges begin to move inward. That's when essentially our skin is trying to grow back to each other, right? It's trying to connect back to each other. If I just went to the next slide, I could just read off this, I guess. And then we get maturation. As scar tissue remodeled, blood vessels disappear, leaving a vascular scar. Scar tissue becomes stronger. Scar tissue can last a lifetime, though, right? Depending on how severe the site of injury truly was. There's only a couple type of cells within our body, such as, I wonder if it's going to say it on here. No. Such as like, I think bone marrow and liver cells or liver enzymes or hepatic enzymes, if you will, that are capable of total regeneration. That's what's funny is that if your liver is essentially wounded, or I don't know, if part of your liver was to die off, your liver can actually regrow itself. And bone marrow cells are the same way. That's why when you have a broken arm and they cast it, or they have a broken leg and they cast it, it's because your bones can actually regenerate and reattach to each other, right? Total regeneration is a process called hyperplasia, again, which we kind of talked about a little bit early on in this chapter when we talk about cells coming together. The healing process produces new tissues that might not be identical to the old ones, and they're generally not as strong as well. What I noticed when I broke my arm, I actually used to be left-handed. I broke my left arm and had to learn to do everything with my right hand. And what I had noticed actually over time as well is that my left hand or left arm just isn't as strong as my right arm for some reason. It's not because of dominance or anything like that. It's just a simple fact that I can't bear weight on it the same. And maybe that's just me. Maybe that's how it just in my mind, but it's just something that I've noticed. Dysfunctional wound healing. This could be insufficient repair, excessive repair that might take a long period of time. Some causes of this are due to factors such as genetic factors, such as diabetes, lifestyle factors, maybe. We're inhibiting our body's ability to fight off infection. We're inhibiting our body's ability to regrow and to really start to rebuild itself, just based off of simple stuff. diabetes is an increased level of blood sugar generally in the bloodstream. So we could get some levels of necrosis there. Hypoxemia, or a lower level of oxygen inside the bloodstream. Remember, oxygen and glucose are what's needed for the body to function. So if we have a reduced level of oxygen, it might not be able to regrow like it normally would. Nutritional deficiencies. Okay, our body doesn't have the energy, again, to fight. And then certain drugs can inhibit this as well. Positioning, if you're cutting off blood supply, certain exercises, drugs, some of these things can assist or actually, believe it or not, hurt in wound healing as well. All right, age and mechanisms of self-defense. So I kind of said this a little bit earlier, right? Newborns and elderly, two opposite sides of the lifespan, right? More susceptible to problems of insufficient immune and inflammatory responses. Infants, it's because they don't have the ability, they don't have the immune system built up yet, right? They haven't been exposed to a whole lot at that point. About halfway through their first year of life, their immune system essentially, I would say starts to kick in at that point, and they start to build it. But anything prior to that, they can get sick really easily. And even at 6 months, the immune system is really, really immature, right? It's not used to it. It's not used to being callous like we are, being exposed to certain colds, certain sicknesses, and they don't have vaccines or anything like that inside their body to help them fight off any potential infections. So their body is more susceptible to infections, especially respiratory infections, right? That's why a lot of younger children as well, as you see their nose running, is because their body's developing a new immune system and they're fighting something off at that point. Elderly population. It's just, remember, they have a decrease in those B and T cells. Their body can't fight like it used to, and their skin is a little bit thinner. They don't have wound healing processes like we do anymore. And it's nothing wrong. It's not because they've done anything wrong. It's just a normal process of aging, right? We start to lose things as we become older. That's why a lot of elderly patients are on medications such as anti-inflammatory drugs for arthritis, because they have chronic inflammation issues, right? Hypoxia. They begin to develop COPD potentially, especially if they've had some lifestyle issues. Hypoxia can lead to reduced blood supply into blood vessels, or reduced oxygen in the blood vessels, which can inhibit the healing process. They don't have, if you notice, as people get older, they generally lose weight. So again, their skin's more vulnerable to tearing. They also lack some mobility. Maybe their balance is off. That's what potentially leads to falls, and falls leads to wounds in our elderly population. All right, variances in immune and inflammation. Hypersensitivity is essentially when our body sends an exaggerated and harmful immune response when it really isn't warranted. An allergy, exaggerated immune response to the environmental antigen. This would be, again, maybe somebody developing hives, a very mild allergic reaction. Autoimmunity is what our body develops to deal with self-antigens within our body. So when we talk about exposure to an antigen, we're looking at the original insult. These are just key terms to remember. Genetic makeup of a certain antigen. You can have an immediate hypersensitivity reaction or a delayed hypersensitivity reaction. That's why patients that have had an allergic reaction, if we go on those types of calls, somebody that's having an allergic reaction, we give them Benadryl, or maybe they just haven't had a reaction yet, but they know they're allergic to something. That's why you probably should hang out there for a little bit. Don't just sign a refusal and leave, because their allergic response can actually be a little bit more delayed. It doesn't have to be right there, right now. It can actually take a little bit of time to get to that point when they start to have a reaction. Let's take a 10-minute break. Come back here at 6:55, and then we'll kind of go over some of the indications of responses and things that we look for, especially with somebody having an allergic reaction. So take a 10-minute break. We'll come back. All right. So clinical indications of hypersensitivity responses. How can I say that in a much simpler term? Anybody?
What did you say, Rudy? Sorry.
Clinical indications of hypersensitivity responses, what it says on the screen in the headline. How could I say that in a simpler term?
Allergic reactions.
Yeah, the clinical indication of allergic reaction. So flushing, we know we get flushing of the skin due to vasodilation of the blood vessels. We know we get itching, right, due to histamine as well. What is another name for urticaria?
Hives.
Hives, right? And then we get edema. Why do we get edema? There's two different reasons. Inflammation, for one, and for two is as our blood vessels dilate, remember they become something which is called semi-permeable. So essentially the walls of them change and they leak out any fluid that is not blood. That's why we essentially kind of swell up a little bit. Now, when we give something such as an EpiPen, we're actually forcing that fluid back into the blood vessels, reducing swelling, reducing inflammation. We're causing the blood vessels to constrict, which reduces our flushing, and we're giving something such as Benadryl, which is an antihistamine, to reduce our hives and reduce our itching. Now, when we have like anaphylactic reactions, how do we know the difference between a mild allergic reaction and a true anaphylaxis? If your patient goes from having hives to now having breathing problems, you should probably be looking at administering epinephrine. Anytime they're having difficulty breathing, difficulty swallowing, laryngeal edema, so airway swelling, laryngospasms, bronchospasms, and I'll even throw one in there, bronchoconstriction. Remember, anything with broncho means lungs. Anything with larynx is generally upper airway. We have cardiovascular issues as well, right? We vasodilate, we become permeable, so we're being to leak fluid. Our heart rate increases and our blood pressure. We can have some GI symptoms as well for a hypersensitivity response. Nausea, vomiting, cramping, diarrhea. Nervous system. Patients generally feel dizziness. They feel headache. If it's so severe that it's causing convulsions, that is a true anaphylactic emergency, right? Anaphylactic emergencies are life-threatening. They truly are. Think about it this way. We've talked about anaphylactic reactions a little bit, a severe allergic reaction in some patients. We treat it with epinephrine, right? We treat it with Benadryl. What then? How do we manage that patient? Are you going to let them refuse? I mean, you don't have a choice if they're, alert and oriented, but do you want them to refuse? And how many EpiPens can we give during transport? Or how many doses of Epi can we give?
It's just one, right?
Nope.
2.
If their response comes back so severe, I'd give another one. What is the dose of epinephrine we're looking at giving somebody an allergic reaction, an adult?
0.3
Okay, of what concentration?
of 1 to 1,000.
Okay, so which route is that then?
I am.
1-to-1 is never given IV. We never give Epi 1-to-1 IV because it'll actually, I'm not joking, you'll explode somebody's heart. If we're going to give Epi IV, it has to be 1 to 10,000. You can give the same dose, 0.3 to 0.5, 1 to 10,000 IV. There's nothing wrong with that. But just make sure you are not giving 1 to 1,000 through an IV or through some sort of intravascular access. So there's 4 different types of reactions.
Hey, Rudy,
We talk about, yeah.
could you dilute that down, that 1 to 1,000?
How do you make 1 to 1 to 110? How do you make 1 to 1 into 1 to 10?
I'm not sure on that, but I was thinking about just diluting that with 3 milligrams of normal saline. Would that
Yeah,
be
but-
correct?
Then that makes epi 1 to like 4,000.
Oh, I don't know.
Okay, so let's riddle me this. There was an epinephrine 1 to 10 shortage for a while, to where we couldn't get it. So we were literally carrying epi 1 to 1 in a saline flush in a needle. You put them together in a little pack. So how many mLs are generally in a saline flush?
10.
Okay, so if I expel 1 ml, that gives me 9, and then I suck up 1 ml of 1 to 1,000. What now do I have?
One to 10.
Yeah, I made 1 to 10. Good question, and it's actually something that a lot of people don't know how to do, is make 1 to 10 out of 1 to 1. But yeah, if you have a 10 ml flush, get rid of 1 ml, and then suck up 1 ml of epi 1 to 1, and that makes epi 1 to 10,000. That makes sense?
Yeah.
And honestly, and that's something. Bring that up during skills lab sometime. We'll practice dilution of it. Seriously. All right, 4 mechanisms by which tissue-specific reactions attack cells. We're going to look at the types here quickly. Where'd they go? We're not going to look at the types yet. Never mind. So we have a hypersensitivity towards a targeted antigen, so an allergic reaction, right? This can be allergies due to environmental antigens such as pollen, such as hay. It could be autoimmunity such as self-antigens, maybe something within your body itself that the body's trying to attack. Or it could be isoimmunity, which is somebody else's antigens that essentially you've breathed in or something of the sort. Remember, an allergen is something that targets a specific allergic reaction. It has a specific destination. We talk about autoimmunity, break down the body's tolerance for self-antigens. Immune system attacks body's own cells. We talk about autoimmune. That's when we talk about like autoimmune disorders. Can anybody list any autoimmune disorders by chance?
Eczema,
Okay. What's another one?
psoriasis,
Okay. What's another one? What about HIV? That's a big one, right? That's the body again is essentially attacking itself, right? We don't have that autoimmunity buildup that we want that attacks what it should be attacking. Instead, it's attacking ourselves. Isoimmunity, one member of a species has immune reactions to cells from another member of the same species. Again, that causes them to attack themselves. Some of the autoimmune and isoimmune diseases. So Graves' disease. Does anybody know anybody with Graves' disease by chance? People with Graves' disease generally have symptoms of hyperthyroidism, which we'll talk about when we get to medical, which is usually elevated heart rate, elevated blood pressure, increased appetite, and they generally have like bulging eyes. I know that sounds weird, but like literally their eyes will be like bulging out of their head. Everything is increased with Graves' disease. The way I remember Graves' disease is it's truly the opposite of being in the grave. Everything is elevated, as to where you would think it'd be depressed being called Graves' disease. Everything's elevated. Heart rate's elevated. Blood pressure's elevated. You're hungrier. You have an increased activity level, and you got bulging eyes. That's how to remember it. Okay. Rheumatoid arthritis, inflammation of the joints, leads to essential destruction of the interior of a joint, which these people generally live with pain pretty long. Myasthenia gravis, disease caused by antibody-specific response on acetylcholine receptors in striations of skeletal and cardiac muscle. So these people generally have like episodes of muscular weakness. It's really hard in the field. We don't diagnose that. It's really got to be diagnosed by immunologist. Some of these other ones, you have ITP. Gosh, I got to learn not to scroll. You have ITP, isoimmune neutropenia, lupus, I actually, somebody I know that I worked with had lupus really bad. Does anybody know anybody with lupus and like what it causes with them by chance? So it's really essentially inflammation of the joints as well. And generally, these people can get really pale and they get really cold for some reason. It's really hard for them to maintain their body's temperature. It's essentially the antigens that they have, self antigens that are within their body. Again, attack red blood cells. They attack anything and everything. And then your white blood cells turn on yourself. Your platelets turn on yourself, which eventually leads to degeneration of the joints, tendons, and even organs. To be honest, over a long period of time, it's not managed. So immunity and inflammation, congenital deficiencies, things we can inherit from our parents, right? Generally, it's from our mother. Acquired immune deficiencies developed after birth do not result from genetic factors. So that could be, again, just based off of development when we were nothing more than a fetus or an embryo. Nutritional deficiencies, deficiencies caused by trauma, deficiencies caused by stress, immunodeficiency syndrome, AIDS, human immunodeficiency virus. You know, for the longest time, when HIV first came out, it was like everybody was terrified of HIV. It's still something I'm not downplaying it by any means, but it was, oh my God, this is going to be a disease to kill everybody. You know, your body can't fight anything. Your body's fighting itself. It's attacking itself. But today's day and age, honestly, there are so many medications now to treat HIV, to treat AIDS. And I think I told you guys last week, I read an article about somebody that their own body, for some reason, self-treated and cured themselves of HIV. Very odd. And I wanted to read more on it, but I kind of forgot to. When we talk about AIDS, it's really the best known immune deficiency disorder. It's really a syndrome of disorders. So it's all these different disorders that come together to develop from an infection of HIV, right? HIV itself, how do we usually contract HIV? It's through usually sexual intercourse or something of sort. It used to be that, you know, everybody was so scared, you can't touch somebody with HIV, you'll contract it. You can't touch the blood of somebody with HIV, you'll contract it. You can't, you know, drink off the same glass as somebody with HIV, you'll contract it. That's really not true at all. It really has to be like blood to blood or body fluid to body fluid, or something of the sort. It really isn't that easily passable like many people thought for years. HIV can affect anybody, male or female, doesn't matter, sexual orientation or not. Again, mostly through the exchange of bodily fluids, or even sharing needles when you talk about like addicts or heroin addicts or anything like that. Preventive measures, there's even medications that they have. Again, they can stop HIV in its tracks. And what we know as one of the most famous people that deals with it is Magic Johnson. Until recently, 90% of those people that were infected with AIDS died within 5 years due to severe symptoms. So you can kind of understand why people were so scared and so worried about it. But that's really changed in recent years. It's not really known if we're truly eradicating AIDS or if we're truly just treating it to the point that it doesn't exhibit symptoms. But we can essentially make AIDS idle, right? We have treatments that'll suppress that virus itself, and kind of knock it down deep to where your body can essentially try and fight it off a little bit. It doesn't essentially kill it or take it away, but we have medications to fight it now. We also have replacement therapies, right? Globulin therapies. So this would be people that don't have those B's and T cells to fight off infections. This is essentially giving them B's and T cells through transfusion. Transplant and transfusion itself. So maybe a bone marrow transplant due to lack of the ability to regenerate. That's a thing. Transplant of organs, potentially, that maybe needs to be able to assist in a fight, such as a liver. Gene therapy. Okay. Therapies involving identification of defective genes within the body itself and a replacement of those with essentially cloned normal genes. The advancement in medicine is scary at how much they can do. When they can go in and say, okay, this is a bad gene within you, we're going to take that one out and put a fake one in there. That's terrifying. Stress and disease. So, how many of you have never experienced stress? Has anybody here just never been stressed about anything in their life? If you say me, or you raise your hand or put a comment or something like that, you're a liar. So stress is a state of physical and or psychological arousal to a stimulus, right? Stress happens every day. And at some point during the day, something stresses us out. I guarantee it. But we need to know what things to look for with stress, right? So we can see patients with sweaty palms, feel like their heart's going to beat out of their chest. We generally get stressed right before we have to do something that we're not used to doing, such as, giving a speech or standing up in front of a bunch of people and talking. It's okay. Stressors are the things that are going to cause those stress, right? Like, I don't know. I'm not afraid of heights, but I'm afraid of falling. So if I'm up in a high area and something goes wrong, I start to get a little bit nervous. I'm deathly afraid of sharks. They're a stressor of mine. Thinking about them causing me stress. Spiders, not my cup of tea either. So stressors, things that can essentially exhibit a stress response within our body. Stress over a long period of time can actually start to deteriorate parts of our body as well. We have something called general adaptation syndrome, or GAS. And what this is sorry. This was actually found on accident. Somebody that was studying something else came across this for some reason, but realized this is how our body reacts to stress. As we get an initial alarm to stress, or some stressor has essentially freaked us out, right? We try to resist it, or we adapt to that stress. And then eventually we kind of, over a long period of time, experience exhaustion or burnout due to stress, where the person can no longer cope with or resolve the stress, and physical illness may ensue itself. If you've ever been so stressed that you just feel like you need to go to sleep, or you feel like you're going to throw up, or you feel like you have a massive headache, that's generally what is going on. All right, physiological stress, or physiologic stress itself. Stressors that initiates disturbance, chemical or physical disturbance stressor produces, and then the body's counteracting response. So when we talk about physiologic stress, that's the toll that's taken on our body, right? That's how our body reacts to it. Our sympathetic system kicks in, our pupils dilate, our heart rate increases, our blood pressure increases, our vasculature constricts. So now we've got an increase in blood pressure. We've got these things going inside of our body. We're hyped up. We're elevated. We're scared. Physiologic stress is how our body responds to stress. What changes inside of our body? I don't know if I 100%. Gosh darn it. I don't know if I 100% believe this. No direct correlation between stressor and response. If they mean that the response is triggered, yes, I would agree with that. But absolutely, it depends on the stressor. If your body is going to have a response, to be honest. Total body response to different stressors must be specific. Again, it depends on, it could be something as simple as a fear, something that scares you, could inhibit that stress response. So our body releases hormones in response to stress, right? So catecholamines, natural catecholamines within the body are norepi and epi. If you ever have a patient tell you they're allergic to epinephrine, they're a liar. You cannot be allergic to epinephrine. It's a natural catecholamine within your body. Cortisol. Does anybody know what cortisol is, or ever heard of that before? Okay, we'll come back to it. Beta endorphins. So when we talk about beta endorphins, beta 1, so we're going to get an increase in heart rate. Beta 2, we're going to get bronchodilation and vasodilation. It actually releases a growth hormone as well, right? And then we get something called prolactin. little diagram of how our body responds to stress. So stressor, then our central nervous system kicks in, as well as our physiologic and psychological responses. Our body then releases its natural catecholamines, such as norepinephrine and epi, to essentially get us that sympathetic system kicking in, that fight or flight system, right? All right, the physiologic effects of catecholamines. So epinephrine and norepi. This, again, we're just referring to norepi and epinephrine in this. Our brain, we get increased blood flow to the brain because of vasoconstriction. Remember, we're locking down our blood vessels to give the maximum amount of blood to our vital organs. Our brain's pretty vital. Our vascular system speeds up our heart rate through our beta-1 receptors, so we get increased contractile force and rate. Pulmonary system, we get bronchodilation, which improves oxygenation and actually improves our oxygen supply and store. Now, since we're going to have a fight or flight reaction, our body says, gosh, I'm going to need a lot of energy here. So our liver increases glucose production, so that way we can have a store of energy built up, right? Our GI tract decreases protein synthesis, and our muscles begin to contract and dilate of vasculature. They want to dilate the vasculature because they want the massive amount of blood flow to the muscles in case they need to use them, right? In case we need to run, we want that blood flow. Our skeletal system decreases glucose uptake and utilization. Why would it do that? Because during our fight or flight response, our glucose is being directed to our brain. Fatty tissue, increased fatty acids, increased lipolysis. Our skin gets decreased blood flow, so we might become a little bit pale. Have you ever seen somebody that's like terrified, they get scared really bad? They turn like a pale color. That's because their body just did all of this stuff in a matter of 10 seconds. And then our lymph tissue, increased protein breakdown, again, to give us nutrients, to give us energy. So our body does all these things to increase how we respond to a stressor. I kind of brought up cortisol and asked what cortisol was. It's another hormone produced in response to stress. Cortisol actually assists in stimulating the sympathetic nervous system. I'm not going to go through each one of these because I feel like it wouldn't actually help you guys to be honest. So, having to do with our cardiovascular system, some of our immune-related diseases and conditions, obviously, when we talk about our heart, coronary artery disease, also called potential atherosclerosis, or we get plaque buildup within our coronary arteries, which can eventually lead to an acute myocardial infarction due to reduced blood flow. We get hypertension, potential stroke, especially if somebody has an irregular heartbeat. AFib is a precursor to somebody that they could potentially have a stroke, because AFib, again, is an irregular heartbeat, so they don't get a good pump of blood with each squeeze. So at some point, that blood begins to pool up and on the bottom of the ventricles, and then when it does squeeze, it could essentially throw a clot. Muscles, back aches, joint aches, tension headaches, retentive tissues, we're talking joint problems, rheumatoid arthritis, pulmonary system, asthma, hay fever, COPD, immune system, any of those autoimmune deficiency disorders potentially, any of your GI system, issues such as ulcerative colitis, Crohn's disease, maybe a peptic ulcer, irritable bowel syndrome or IBS. All right, those who cope positively with stress have a reduced chance of becoming ill. Those who don't have greater chance of becoming ill. There's a reason why in our profession, in EMS and fire or whatever it might be, an emergency response, why is it that we say we have to deal with stress? Because in our 12 or 24-hour shift, we'll probably see more stressors than somebody will see in their lifetime. Think about that for a second. More in a 12 or 24-hour shift, we will see more stressors than somebody will see in their lifetime. What happens when that stress takes a toll on us over time? Seriously, what happens? Our body begins to break down, right? We become sick. We become depressed. That's why dealing with long-term stress and dealing with long-term anxiety or some sort of illness, is pretty vital in this career, and learning how to cope with it, whether it be talking with somebody or, you know, working out or whatever it might be, and trying to lead a healthy lifestyle is pretty important in this line of work. All right, I think I've got a couple of videos here. Let me reshare this so you guys can hear it. Just on how the immune response system works and stuff like that. Let me know if you guys can hear this or you can't hear it. Again, just let me know as soon as it starts playing, so that way I can figure out if it's going or not.
You may not know it, but your body is engaged in a never-ending battle. You are literally covered in staph
You guys hear that?
Yep.
Perfect.
and strep and E. coli and all sorts of dubious characters that are intent on using you and your body's many resources to feed themselves, find shelter, and reproduce as much as they want. And hey, we all gotta make a living, but it is not your job to give these guys a free lunch. So your body has developed a 3-part policy toward these shady customers, and its enforcement is handled by your immune system. The immune system is different from all the other systems we've talked about this year in that it's not a specific tissue, organ, system kind of system. Instead, it involves a whole bunch of different tissue groups, organ systems, and specialized but widely distributed defense cells. Together, this league of extraordinary substances joins forces to perform all of the defense functions your body depends on to keep you alive in an incredibly germy world. And the first line of defense in this never-ending battle, that's your innate or non-specific defense system. Like your average frontline soldier, it's prepared to immediately engage with anyone suspicious, and it mostly includes stuff we were born with, like the external barricades of your skin and mucous membranes, and internal defenses like phagocytes, antimicrobial proteins, and other attack cells. But some enemies must be fought with special forces, and here your body can deploy your adaptive or specific defense system, which is more like your SEAL Team 6. It takes more time to call in, but it's specially designed to go after specific targets, and it keeps files on those bad guys so it knows how to handle them next time around. But today we're going to focus on your innate system and look at how it uses an arsenal of physical and chemical barriers, killer cells, and even fever to keep you healthy, proving that sometimes the symptoms we associate with illness are actually the signs that we're healing. Just because something is simple doesn't mean that it can't be elegant. I mean, your body is capable of some incredibly sophisticated things, including defending itself from infection. But occasionally, there's something to be said for brute force. And a lot of your innate immune system's functions aren't exactly subtle. For example, your body's very first line of defense is a simple physical barrier. And it works. Like a wall around a fortress, your skin does a fantastic job of keeping out all manner of malevolent microorganisms. As long as that tough, keratinized epithelial membrane doesn't get torn open or busted up too much, you could probably, like, make snowballs out of raw sewage and still be all right. Although, no. Your many mucous membranes also provide a handy physical barrier. You'll remember that they line any cavity that opens up into the germy outside world, including the respiratory, digestive, urinary, and reproductive tracts. Not only do your skin and mucosa supply simple physical protection, they also pack some serious chemical weaponry. Eat some questionable leftovers for lunch? Don't worry, your stomach is literally filled with acid, so you probably are covered. Walk face first into your coworker's nasty sneeze cloud? No worries, your nasal passages can whip up a tissue box worth of sticky mucus to help trap viruses before they enter your lungs. You've also got bacteria-fighting enzymes in your saliva and lacrimal eye fluid, and peptides called defensins in your skin and membranes that help keep bacteria and fungi from setting up shop around inflamed or scraped skin. Which, no matter how careful you are, you're gonna get one way or another. Maybe you shave with a dull blade, or you just brush your teeth too hard, and don't get me started about the dangers of bagel cutting. So when you've breached that first simple line of defense, it's time to call on your second line of internal innate defenses. This is where your body starts pulling strategic maneuvers like firing up a fever, releasing chemical signals, causing inflammation, or other defensive tactics that help identify and attack infectious invaders. Some of the first defensive cells on the scene are your phagocytes. Their name literally means to eat, and like Pac-Man, they indiscriminately chase down intruders and gobble them up. And and they come in a few different varieties. First, you got neutrophils, which are the most abundant type of your white blood cells. They kind of self-destruct after devouring a pathogen, and in fact, you've probably seen piles of their little dead bodies, because that's what pus is made of. But the bigger, tougher phagocytes are the macrophages. They're derived from monocyte white blood cells that have moved out of the bloodstream to occupy tissues, and some are free types that patrol tissues looking for creepers, while others are fixed, attached to fibers in specific organs, devouring anything suspicious that passes by. So when a macrophage, in say the finger I just cut slicing a bagel, sees a new bacterium coming along, it snares it using cytoplasmic extensions, reels it in, completely engulfs it, and essentially digests it and spits the rest out. And unlike neutrophils, it can do this over and over again, like a boss. But not all your defense cells are phagocytic. You've also got cells with what is by far the awesomest name of any cell in the body, the natural killer cells. You can call them NK cells if you want to, but like, why would you do that? Anyway, these tiny assassins patrol your blood and lymph looking for abnormal cells and are unique in that they can kill your own cells if they are infected with viruses or have become cancerous. How can they tell? A normal, healthy human cell contains a special protein on its surface called MHC1, or major histocompatibility complex. But if it's infected, it stops making that protein. And if an NK cell detects a defective cell, it doesn't swallow it whole like a macrophage. It pokes it with an enzyme that triggers apoptosis, or programmed cell death, which is pretty awesome. So those are some ways your innate immune cells handle their enemies, but how do they know where to look in the first place? So let's talk strategery. So say you're in a banana factory and you slip on a banana peel and you scrape your knees. Your outer fortress has been breached and the pathogens are just flooding in like orcs through Helm's Deep. Banana factories are very dirty places. Now your body wants to contain the spread of pathogens, clean up the mess, and get healing as quickly as possible. So it cues up your inflammatory response. This is basically an internal fire alarm, only it uses chemicals instead of sirens to get the message across, and instead of smoke and fire, you sense redness, swelling, heat, and pain. For example, in the event of injury, specialized mast cells in your connective tissue send out histamine molecules, and histamine is great at calling in the cavalry. For one thing, it causes vasodilation, which creates redness and heat at the site of the injury. Now, those things might freak you out a little, but they're actually signs of healing. The increased temperature, for example, ratchets up the cell's metabolic rate so they can repair themselves faster. Meanwhile, histamines and other inflammatory chemicals also increase the permeability of blood vessels, causing nearby capillaries to release protein-rich fluids. This causes swelling, which again is actually a good thing because that leaked protein helps clot blood and form scabs while the lymphatic system sucks up and filters that extra fluid, cleaning it up before putting it back into your bloodstream. And of course, like chum to sharks, an inflamed knee is also going to attract a bunch of local phagocytes, which find it easier to escape your now leaky capillaries, and lymphocytes that are also flowing freely, helping to destroy pathogens while also cleaning up dead cell wreckage. And don't forget, during all this, the neutrophils have been doing their best, but they were the first wave to arrive, so by this time, they're starting to die in heaps. They're triggered when the injured knee skin cells release chemicals that begin leukocytosis, the release of neutrophils from the bone marrow, where they're made, into the bloodstream. To attract the neutrophils to the damaged area, inflamed endothelial cells in the capillaries send out chemicals that act like homing devices. And when the neutrophils arrive, they cling to the capillary walls near the injury, flatten themselves out, and squeeze through the vessel walls to get to work. Your big monocytes eventually roll up to the battle and transform into hungry macrophages, replacing the first line of now dead neutrophils and basically just eating up any lingering enemies and then cleaning up the carnage. Now, all this works pretty well in most circumstances, but you may have noticed with a more major injury or an especially nasty virus or infection, sometimes your local troops get overrun. When white blood cells and macrophages run into more foreign invaders than they can handle, they let loose pyrogen chemicals that tap the hypothalamus and raise your body's thermostat, calling in a systemic fever to burn everything. The resulting temperature rise increases the metabolism of your cells so they can heal faster, and it also tells the liver and spleen to hold on to all of their iron and zinc so those things can't contribute to bacterial growth. But even then, sometimes you find yourself facing a more formidable foe. That's when you call in the specialists, your adaptive immune defenses. And to learn exactly how they save the day, you have to watch next time. But for now, you learn that your immune system's responses begin with physical barriers like skin and mucous membranes, and when they're not enough, there are your phagocytes, the neutrophils and macrophages. You also learned about natural killer cells and the inflammatory response, and watched as all of these elements saved the day when you slipped on a banana peel. Thank you to our headmaster of learning, Lenaya Boyev, and thank you to all of our Patreon patrons whose monthly contribution.
I know he talks kind of fast, but he's actually kind of amusing to watch. I'll send you guys the link actually to a lot of his videos because he explains things a little bit easier, and he's very He actually teaches pathophys for a living. So he's very informational to watch, and you might learn something from him that maybe I don't cover, or maybe I don't go real in depth on. All right, the next video I have here is how our inflammation response works. I have a series of 3 videos here that we're going to watch. Is how our inflammatory response works in conjunction with our blood vessels, in conjunction with our clotting, how this all kind of takes place.
The inflammatory response is initiated within hours of infection or wounding and is characterized by edema or swelling, heat, redness, and pain at the site of an infection or injury. These characteristics reflect 4 changes in local blood vessels. 1. The heat and redness during inflammation is the result of an increase in vascular diameter. The increase in vascular diameter also results in slower blood flow. 2. There is also an increase in vascular permeability. The endothelial cells that line the blood vessel walls are usually packed tightly together, but during inflammation they have gaps between them. This results in fluid from the blood exiting and accumulating in the local tissues, and this results in edema and pain. The fluid contains plasma proteins such as complement proteins and mannose-binding lectin, which aid in defending against pathogens. 3. Endothelial cells, which line the walls of blood vessels, are activated during inflammation. That is, endothelial cells express cell adhesion molecules that promote the binding of circulating leukocytes, otherwise known as white blood cells. 4. There is clotting in the microvessels at the site of infection, which prevents pathogens from spreading via the blood. The purpose of the inflammatory response is threefold. First, it allows the body to defend itself from invading microorganisms. The increase in vascular diameter, along with the activated endothelial cells, results in leukocytes being able to attach to the endothelium, and then migrate into the tissues where they can attack pathogens. This process of leukocytes leaving the bloodstream and entering tissues is called extravasation. Second, it induces local blood clotting, and this creates a physical barrier which prevents the infection from spreading into the bloodstream. Third, it promotes the repair of injured tissue. But what triggers the inflammatory response? The state of inflammation is set up when tissues are physically damaged, or when pathogens are recognized by macrophages and later by other white blood cells. Either of these circumstances induces the release of a variety of inflammatory mediators which cause the inflammatory response. Macrophages and neutrophils secrete prostaglandins, leukotrienes, and platelet activating factor, or PAF, which are lipid mediators of inflammation. These are produced rapidly because they are made from degraded membrane phospholipids. Then, macrophages secrete cytokines, which are substances released by cells of the immune system that affect other cells. One kind of cytokine are chemokines, which act as chemoattractants. Chemokines cause directed chemotaxis, which is the movement of cells or parts of cells in a direction corresponding to a gradient of increasing or decreasing concentration of a substance. In the case of chemokines, they direct phagocytes to move towards the source of the chemokines, which is where they are needed. Now I'd like to point out 2 cytokines important to the inflammatory response: C5a and tumor necrosis factor alpha, or TNF-alpha. The complement fragment C5a plays multiple important roles in the inflammatory response. For instance, it stimulates respiratory or oxidative burst, which is the rapid release of reactive oxygen species. At the same time, it attracts neutrophils and monocytes, so it essentially preps them for battle as they arrive. It also increases vascular permeability, increases expression of certain adhesion molecules on the endothelium, and causes local mast cells to release granules containing the inflammatory molecule histamine and TNF-alpha. TNF-alpha is also an important cytokine, which is produced rapidly by macrophages upon pathogen detection, and is a potent activator of endothelial cells. Activation of endothelial cells is central to the inflammatory response. Cytokines produced by macrophages, especially TNF-alpha, cause endothelial cells to rapidly externalize granules called Weibel pallid bodies within minutes of pathogen detection by macrophages. Weibel pallid bodies contain preformed P-selectin, which now appears on the surface of local endothelial cells. Selectins are one of 3 structural families of adhesion molecules important for leukocyte recruitment, with the other 2 being intercellular adhesion molecules, ICAMs, and leukocyte integrins. Later, within 2 hours of pathogen detection, the endothelial cells primarily express E-selectin. This is because shortly after P-selectin gets to the cell surface, mRNA encoding E-selectin is synthesized. Both selectins interact with the sulfated sialyl-Lewis X that is present on the surface of neutrophils. Once inflammation has begun, neutrophils make up the first wave of cells that cross the blood vessel wall to enter an inflamed tissue. After this, monocytes cross the blood vessel wall and differentiate into tissue macrophages. In later stages of inflammation, other leukocytes such as eosinophils and lymphocytes also enter the infected site. Usually, leukocytes travel in the center of small blood vessels, where blood flow is fastest. However, in inflamed tissues, the slower blood flow allows leukocytes to interact in large numbers with the endothelial cells lining the blood vessels. In addition, injury to blood vessels triggers 2 enzyme cascades, the kinin cascade and the coagulation cascade. In brief, the kinin system consists of plasma proteases. A protease cascade features enzymes that are initially inactive. Activation of one enzyme triggers cleavage and activation of the next enzyme in the cascade, and so on. The eventual result of this cascade is the production of several inflammatory mediators, including bradykinin, a vasoactive peptide that increases vascular permeability and causes pain. Pain is an important part of the inflammatory response because it makes you aware of the problem and causes you to immobilize that part of your body, helping prevent the spread of infection. The coagulation system is another protease cascade whose activation leads to formation of a fibrin clot. This prevents blood loss in the case of blood vessel damage and physically blocks the spread of pathogens in the case of infection. If you enjoyed this video, like and subscribe. You can also support me by following the link to my Patreon. If you have any topics you'd like me to cover, please leave a comment.
Again, I cannot stress this enough that I don't expect you guys to remember a ton of this stuff, but I expect you to remember what systems kick in. I'm not looking at cell specific, but when there's an injury, when we have an allergic reaction, how vasoconstriction works, how vasodilation works in response to shock, how our heart rate kicks up, and we have these baroreceptors. That's the one big thing that I feel like people get tripped up on the most is we have these baroreceptors that monitor our blood pressure levels. Well, as it sees a drop in blood pressure, it increases our heart rate to try to make up for it, right? That's what we call compensated shock. So I expect you to remember just some of this stuff. I'm not going to go. I've never heard of anybody having on their national registry or anything like that macrophages or phagocyte cells or neutrophils or leukocytes, because it's not something that every paramedic program gets really in depth with, and it's not something that I want you guys to spend so much time on worrying about, because again, I won't test you on that because I feel like it's not super important or super pertinent to your education, but the body system itself is, as to how that system works and how it kicks in. I might be shooting myself in the foot here when I ask this. Any questions over like the inflammatory response or the immunologic response? I suck with pronouncing words like that. I apologize. No? All right, any questions? Any questions at all? No? All right. I have this little video here that, if I remember right, I believe it's this one here. Has anybody ever seen Osmosis Jones by chance? On how white blood cells attack intruders? Has anybody ever heard of this movie?
I think it's on Netflix right now.
It should be. It's actually pretty neat. I actually watched portions of it. It's a cartoon. It has Chris Rock playing like the main character, and it's some of the stuff is kind of elaborated. Some of the stuff really isn't true at all. But like in this instance here, it's essentially white blood cells tracking down intruders in the body.
Son of a flatulence! They strike the patrol car! We got multiple germs, I repeat, multiple germs coming down the windpipe. And if these bad boys hit the bloodstream, we're gonna be villains. I'm talking nose stripping, chicken soup drinking, rectal thermometer sticking LN. What's mission to
Listen to this.
Oh, you got plans for the weekend, kid? Oh, yeah. Me and my girlfriend are going down to the kidneys to see the Stones. Good for you. They could pass any day now.
All units south of the stomach, be on the lookout for illegal organisms.
Stones, you want to keep your job? Stay where you are and wait for backup. And I can get them. I said stay put. Over. You heard the chief. We're out of our jurisdiction. It's immunity's problem now. We better get back up to the mouth. What the? Hey, Jones! Chief, you're gonna thank me for this later. Don't even think about it, pal. Aren't you in enough trouble already? Jones! Shouldn't you be up in the mouth? Come on, guys. This is my bus. That's on first. You want osmosis? You got it. Bye-bye, cop. Sorry, baby, but it's time you take your medicine. Dang, always pulls to the right.
Anyway, kind of a neat movie. If you get a chance, if on Netflix, by all means, watch it. It's kind of cool when it talks about white blood cells. And if you saw there when he went through the brick wall and he talked about osmosis, so moving from one concentration to the next, it gives subtle hints to pathophysiology. And if you got kids, it's a great movie. They'll love it. As far as tonight, that's as much as I have for PowerPoint wise. Thank God we're through the Pathophys chapter. It is probably one of the hardest chapters to go through in terms of going through your paramedic education. But let's talk about your final real quick. Next week, we're going to do a review of your final and cover some of the stuff that is going to be on your final. I'll tell you, it'll be open book, but the book isn't going to help you 100% because a lot of the questions are scenario based and there are a lot more critical thinking questions. Yeah, there's some questions on there that is, what is this or what is the definition of this? But a lot of them are scenario based, having to deal with all the chapters we've covered so far in first semester. So looking at airway, respirations, looking at, shock, looking at allergic reactions, looking at medication administration, looking at pharmacology. Again, your book might not help you a whole lot if you don't know some of this stuff and you can't start putting together some critical thinking aspects of this job. It's 100 questions. Each question is worth 1 point. So it should be pretty straightforward, and I'll be able to gauge where you guys are at for second semester and what things we need to kind of pull our brains towards. Now, I'll tell you, a lot of my tests from here on out are going to be critical thinking tests where you're going to have to think a little bit above and beyond just more than definitions, but how you would truly treat patients and how you would break down a question, just like an REMT question, looking for things that it's specifically asking. The number one reason that people tend to fail the National Registry or not get through an exam isn't because of lack of knowledge. It's due to lack of, or the ability to not break down a question. You really can't understand what the question's asking, so you get nervous, you guess, and you usually guess wrong, and also second guessing yourself. So I can teach you all the information. I can't teach you how to take a test, but I can start to try and get you guys in the right mindset for taking a test. Any questions for me? All right, if there are no questions, I will be in the office up until 5 p.m. tomorrow. And then I'm gone the rest of the week, obviously, for Thanksgiving. I hope you guys have a great Thanksgiving. Enjoy time with your families if you're at work. Hopefully you and your crews don't go too crazy during the holiday weekend and during the holiday itself. If you guys don't have anything for me, you're free to go. If you do have any questions or anything like that, I'll stick around and answer any questions for you. But like always, send me an email. Give me a call. Anything you need to do. If there's anything I can ever help you out with, just let me know, okay?
Hey, Rudy.
Yes.
Hey, I have a clinical tomorrow at the CMICU.
Okay.
Is there any way that you could email me a map or kind of point me in the direction I need to go for tomorrow?
Yeah, just hang out here for a second. I'll tell you where it's at.
Okay.
Hey, Rudy, have you heard anything about Iowa City or Waterloo?
I did actually. I have a meeting with them tomorrow morning at 8 o'clock.
Awesome. Sweet. Thank you.
Hey, Nate, you there?
Yeah.
Okay. I'm going to actually post this link on D2L as well for anybody. But cardiac med is on the main level. So if like you go in through the front entrance of the hospital, you know where the Starbucks is in Mercy?
I think I do.
It's literally like down the main. So if you go through the ER at Mercy,
Yep.
like the back doors to get out of the ER, there's a long hallway past the church.
Okay.
If you take that hallway down to Starbucks, all your ICUs are gonna be right there, right just past Starbucks. So cardiac med, neurotrauma, they're all gonna be right there in that section. So it's still on the main level.
Okay.
But
And it'll take a left down the hallway, right?
Yeah. Yep.
Okay.
Yeah, you go down that main hallway. Like if you walk in Mercy's front entrance, you know how there's elevators right there?
Yep.
If you keep going straight down that hallway, you'll run into like the chapel.
Okay.
Take a left at the chapel and you'll see Starbucks in front of you. And then just past Starbucks is like your ICUs.
Okay.
But yeah, I'll post this map on D2L so you can look at it too.
Sure. That'd be perfect. Because I know there's a couple of them I was looking at.
Yeah, no problem, man.
All right. Appreciate it, buddy. Thank you.
See ya.
Rudy, any luck with Mercy North yet?
I didn't meet with them. Actually, the deputy chief of EMS for Mason City met with them. And I sent him over some information on it today, but it sounds like what's going to happen is they're going to allow 2 students at a time in the ER, and they're actually going to open up the OR for you guys as well. So I'm just waiting to hear back from him, and then we'll get you guys scheduled.
Okay. All right. Is the quiz going to be posted on D2L?
Yep, I'm actually going to go in there and open it up as soon as we end this.
Okay.